Picture this. You're in the emergency room. A patient is gasping for air. Their heart is pounding out of their chest. And with every single breath they take, they're not getting better. They're getting worse. This right here is a tension pneumothorax. It's a true medical crisis where every single second and every decision is a matter of life and death.
For this deep dive, we're going to be working from a really fantastic high-yield summary put together by DERKAT Premium Revisions to help us break down this absolutely critical condition.
All right, let's get right into it. To really understand how to fix this problem, we first have to get a handle on what's actually going so wrong inside the chest. So the whole story is right there in that definition. Air gets into what we call the pleural space. That's the little gap between the lung and the chest wall. But here's the kicker. It cannot escape. That's the crucial part. It creates this terrifying one-way valve effect, basically turning that side of the chest into a pressure cooker. The lung gets squashed flat, and eventually, that pressure builds so high it starts squeezing the heart and the major blood vessels, leading to a catastrophic condition called obstructive shock. Yeah, that one-way valve analogy is perfect. Just imagine it. With every single breath the patient takes, more air gets sucked into that space, but none of it can get back out. The pressure just builds and builds and builds. It's a chain reaction. The trapped air collapses the lung, sure, but then that pressure starts pushing everything, the heart, the trachea, the major vessels, over to the other side. It's literally kinking the hose, stopping blood from getting back to the heart, and that is the core of this emergency. So what kicks this whole thing off? Well, it can be something really dramatic, like trauma from a car crash or a penetrating injury. But, it can also happen in the hospital. We call it iatrogenic, which basically means it's an accidental result of a medical procedure, like putting in a central line. And sometimes, especially in patients with lung diseases like COPD, a little weak spot on the lung, we call it a bulla, can just pop. And that's all it takes to start the leak. Okay, so let's talk about what this looks like at the bedside. Being able to recognize a tension pneumothorax is all about spotting a very, very specific pattern of red flags. First up, the breathing. The signs are impossible to miss. Your patient is going to be terrified, struggling for every breath. If you grab your stethoscope and listen to their chest, you'll hear, well, nothing on the affected side. Total silence, because the lung isn't there. It's collapsed. And if you tap on that side of the chest, it'll sound really hollow, almost like a drum. We call that hyperresonance. It's a classic sign. But here's the thing. This isn't just a lung problem anymore. That pressure is now wrecking the cardiovascular system. This is obstructive shock in action. The heart literally can't fill up with blood, so the blood pressure just tanks. To try and make up for it, the heart starts beating incredibly fast. You'll also see the neck veins bulging out because the blood is backing up. It has nowhere to go. And this brings us to a classic textbook finding. Everyone learns about tracheal deviation, where the windpipe is physically pushed over to the other side. But listen, if you are seeing this sign, you are very, very late to the party. This is an ominous sign. It means the patient is literally minutes, maybe seconds, from cardiac arrest. Which brings us to the single most important decision you as a clinician are going to have to make. And you've got to make it right now. So you're standing there. You see the severe shortness of breath. You see the plummeting blood pressure, the racing heart. What do? What is the absolute most important next step? Do you order a stat X-ray? Do you call for a specialist? The answer is you act now. This is a clinical diagnosis. Let me repeat that. A clinical diagnosis. You absolutely do not have time to wait for a chest X-ray to confirm what your eyes and your ears are already screaming at you. Waiting for that picture can be a fatal mistake. If the patient looks like this, you have to treat immediately. Okay, you've made the call. You've diagnosed it based on the signs. What is the immediate, life-saving thing you need to do? The protocol is crystal clear. Step 1 is immediate needle decompression. You've got to let that trapped air out. That's your quick fix. Step 2, for the definitive long-term solution, is to insert a chest tube. And step 3 is supportive care. Crank up the oxygen, get some fluids in if their blood pressure is low. So that immediate fix, the needle decompression. The traditional spot we all learned is in the second intercostal space, right in the middle of the collarbone. You take a big needle, insert it just over the top of the rib to avoid the vessels, and you'll hear this incredible whoosh of air escaping. It's worth noting, though, that a lot of modern guidelines now prefer a site a bit more to the side, in the fifth intercostal space, because the chest wall can be a bit thinner there, especially in adults. So once the immediate danger is over and the patient is stabilized, the focus has to shift. How do we prevent complications? And how do we stop this from ever happening again? When you look at it this way, you can see this direct line between a preventative action and avoiding a total catastrophe. To prevent cardiac arrest, you have to be super careful with ventilator settings. To prevent a brain injury from a misplaced central line, you use ultrasound to guide you. And to prevent this from happening again in a trauma patient, the key is just recognizing the signs early and treating it fast. Every single one of these actions has a direct, life-saving consequence. And really, that brings us to the final and most important question. This isn't just about memorizing facts for a test. It's a call to action. Because when you're faced with that patient who is rapidly collapsing, the only thing that separates a good outcome from a terrible one is your ability to recognize the pattern and have the courage to act without hesitation. So the real question is, could you?